Welcome, this is Fauzi Maluf Filho, Associate Editor for Gastrointestinal Endoscopy, and today we are privileged to have here Dr. Stephen O. from Virginia Mason Medical Center, Seattle, to discuss the recently accepted manuscript entitled Survival and Clinical Outcome After Endoscopic Duodenal Stent Placement for Malignant Gastric Outlet Obstruction, Comparison of Pancreatic Cancer and Non-Pancreatic Cancer. Welcome, Dr. O. Thank you for joining us today.
Thank you for having me.
Could you give us some background of why did you choose this topic?
Sure. Our institution is a tertiary major referral center for the Pacific Northwest, and we have a large cohort of patients who are referred for endoscopic stent placement for malignant gastric outlet obstruction. So we wanted to evaluate the outcomes from our own patient cohort and ensure that the results are consistent with previous reports. And secondly, we were interested in observing if there was any difference between patients with pancreatic cancer and those with other types of malignancies, such as gastric cancer, periampullary tumors, and cholangiocarcinoma. As we all know, pancreatic cancer is characterized by aggressive tumor biology and poor survival. And on this basis, we hypothesized that patients with pancreatic cancer may potentially do worse compared to the other groups of patients.
Okay. And can you briefly summarize the main findings of your research?
The main finding of our study was that the post-stent survival in both groups were similar. So we found that the survival following the stent placement were less than 3 months in both groups, regardless of the type of malignancy that they had. And this really highlights the fact that gastric outlet obstruction is a surrogate marker of poor survival in malignancy, regardless of the type. Interestingly, we've also found that patients with pancreatic cancer tended to have shorter time to stent occlusion compared to the other group, although the difference was not statistically significant and possibly due to a small sample size. Otherwise, all the other endpoints were very comparable between the two groups.
Great. And there was a 1 month post-stent placement mortality rate of 25% in your study. As you mentioned in the discussion section, an algorithm to predict patient survival after stent placement would be useful, correct? Mm-hmm. Which are the selection criteria for duodenal stent placement in your center at the Virginia Mason?
Sure. At our center, life expectancy is certainly a very important consideration, and one would expect, our patients to, survive at least two to 3 weeks to gain the full benefit of endoscopic palliation. In our study, we found two factors independently predictive of post-stent survival, and these were absence of metastatic disease at the onset of the obstruction and post-stent chemotherapy. So, perhaps these two factors can be taken into consideration when developing an algorithm. On the other hand, our goal in some of the patients is to really achieve palliation in patients with very limited life expectancy and allow them to be kept comfortable in their homes. In the past, when endoscopic stent was not available, discharge from an acute hospital setting was very difficult for patients with refractory emesis, but with the advent of endoscopic stenting, this has become a possibility. Yeah.
And the literature supports the concept that patients with malignant gastric outlet obstruction with a predicted survival longer than 3 months benefit from surgical bypass, right? And however, the 6 months clinical success rate of duodenal stent was 65% in your study, both for patients with pancreatic cancer and non-pancreatic cancer. So based on these results, shouldn't we offer duodenal stent for patients with malignant gastric outlet obstruction and a predicted survival longer than 3 months, even those with pancreatic cancer?
Yes, I agree that the patients who survive longer than expected can still be managed effectively with endoscopic stents as opposed to gastrojejunal bypass surgery. The 65% success rate at 6 months is based on the patency of the primary stent that was placed at the onset of the obstruction in our study. And in the remaining 35% who did not maintain their oral intake, about half of these patients went through a secondary stent placement and were able to reestablish their oral intake. And there are studies which have demonstrated the efficacy of secondary stent placement in the setting of an obstructed stent. Obviously, the longer these patients live, the more likely they require frequent endoscopic reinterventions, whereas patients treated with gastric bypass typically do not require reinterventions. So, hopefully more studies comparing the two in terms of the cost effectiveness and the outcome will hopefully help resolve the conflicting opinions in those two modalities.
Great. Another important point, the period of research spans over 10 years, from 2003 to 2014, correct?
Mm-hmm.
In your opinion, how did the evolution of duodenal and enteral stents impact the results of your research?
So prior to 2006, we used wall stent predominantly, and from 2006 onwards, wall flex stent, and these two stents were used in more than 90% of our entire cohort. We did not observe any significant difference between the two types of stents in terms of the outcome or complication rates, and we believe that this is probably largely due to the fact that the outcomes are driven by the nature of the underlying disease.
Perfect. And a final question.
Mm-hmm.
Do you envision the development of new models of duodenal stents for the treatment of malignant gastric outlet obstruction, like fully covered, different designs, etc.?
Yes, so as we all know, there are a variety of stents with different designs available in the market, and they have all shown to be very similar in efficacy and complication rates and so forth. Of interest is a recent report in GIE on the use of a lumen opposing metal stent for EUS-guided gastrojejunectomy. And as we all know, one of the major shortcomings of the luminal stent is a stent occlusion. So it would be interesting to see if EUS-guided gastrojejunectomy would evolve as a viable alternative in future.
Perfect. Dr. Rose, thank you for sharing your experience with us, and I encourage you to visit GIE website to watch this interview. Thank you.
Thank you.